Great. Well, thank you, everyone. It's been a great afternoon, and it's really a pleasure to introduce our closing keynote speaker. I'm John Ianian. I'm the director of the Institute for Healthcare Policy and Innovation. We're one of the co-sponsors of today's event, celebrating the University of Michigan bicentennial, along with the Center for the History of Medicine, led by Howard Markel, the School of Public Health, and the Michigan Medicine Division of Infectious Diseases. As I mentioned, our final keynote speaker is Dr. Paul Farmer, who will deliver the 21st Annual Robert Feckety Lecture, sponsored by the Michigan Medicine Division of Infectious Diseases. This annual lecture was established in 1992 to honor Dr. Feckety's 25 years of leadership and service at the University of Michigan. Dr. Feckety was professor at the medical school and the School of Public Health and the founding chief of the Division of Infectious Diseases here at the University of Michigan. He was recognized globally as one of the discoverers of Clostridium difficile colitis and a research leader in the diagnosis and treatment of this important condition. We are honored to have Dr. Feckety's daughters joining us for today's conference and for Dr. Paul Farmer's lecture in memory of their father. And they shared with me before the presentation a wonderful button from I think this commemoration of Dr. Feckety, their father's retirement, where he's striking the Heisman pose, I believe. It's in the end zone of the Big House, a place where we like to celebrate here at the University of Michigan, and really captures the spirit of a great leader who I did not have the honor of knowing, but I know from others, Dr. Pal Kazanjian and others, what an important leader he was here at the University of Michigan, and we celebrate his legacy with Dr. Farmer's lecture. So Paul is the Cullicatronis University Professor and Chair of the Department of Global Health and Social Medicine at Harvard Medical School and Chief of the Division of Global Health Equity at Brigham and Women's Hospital. And when I moved here from Boston about 4 years ago, one of my goals and aspirations was to host Paul for an important event like this, and it's really wonderful to have Paul join us today and participate in this important occasion with all our other great speakers who you've heard from this afternoon. I've known Paul as a good friend since we were pre-med students together at Duke. So those of you who are here who are college students, get to know your friends well and stay close to them. They may be going on to great things. We were together as medical students at Harvard and later as faculty colleagues at Harvard and Brigham and Women's Hospital in Boston. Since co-founding Partners in Health in 1987, Paul has devoted his wide-ranging talents as an infectious disease specialist, medical anthropologist, and advocate for people living in poverty. He is addressing some of the most challenging health disparities around the globe, and he's inspired many others to do likewise. As many of you know, on the cover of Tracy Kidder's widely read book, Mountains Beyond Mountains, Paul was described quite accurately as the man who would cure the world, including those afflicted with Ebola in West Africa over the past 3 years. Please join me in welcoming Dr. Paul Farmer as our faculty lecturer.
Thank you. I'm breathing a big sigh of relief because when your good friends introduce you, it can go very badly. So thank you, John. Nobody calls him John. Thank you, Zavan, for not embarrassing me. And before I forget, I want to say it's an honor to give the Feckety lecture. And I unfortunately wasn't able to meet him, but also through Powell and others here, have great respect for his work and his legacy as a teacher as well as a clinician. So thank you. I am pathologically upbeat, but the talk that I'm going to give is really not, and it's almost as curmudgeonly as Donald McNeil, actually. By the way, I knew that he was hard-nosed, and we're all afraid of him. But who knew he was so hilarious? So Howard, thank you for bringing us together. So I'm not going to tell a victory narrative, although those could be told. I mean, I'm starting with this image because it's going to end well for her. Okay, this little girl, who I met in a place called Port Loko, and which is in Sierra Leone. And in fact, and Howard will forgive me for this, this is also a very historically shallow way of looking at Ebola, and it's also a shallow way of looking at I was on the phone with John Ayen, by the way. He said, well, could you give me a title? And so I cooked up something rather grandiose. But now I'm stuck with it. So, the inversion of the social contract, I'm going to talk a little bit. I'm talking about the contract between healers, and of course I include nurses and doctors, healers and their patients. And actually a lot of this has been introduced already by Marty, I think in a very compassionate and subtle way. So I'm going to look at the experience, which I'm just processing now, of course. I mean, this is recent history. It's ongoing, as will be my other argument. What is the cost of having nothing in that bank account that Marty mentioned, right? No trust in the bank account. And what are the difficulties of working to control an epidemic when there really is not an obvious commitment to care, right? So, and this is the reason this is such a difficult topic is because, when you're my age and hanging around in circles like I do, people really worked hard to stop the epidemic. This was at one time termed the largest, and Donald may have written this himself, the largest public health effort in the world. My point here is that it was always, from beginning to end, a clinically paltry one, and that there was a cost to that. And that cost was that more and more deficits to that trust account were made. That is, more was taken out of it than was put in. Now, the victory narrative of this girl, just so you know it's coming, involves, that's her father, and she's actually, I think, 11 years old and weighs 27 pounds. And I had not cared for her while she was acutely ill with Ebola, but this is not really an acute disease, right? She was already discharged and had, her peripheral blood did not have evidence of Ebola in it at the time, right? But she was dying, and her father, that sad-looking man, forlorn-looking man behind her, thought she was going to die, and like other members of his family. And I'll talk a little bit about the experience of serious and lethal illness from the point of view of patients. Again, it's been admirably laid out when we're talking about One Health or interactions between the pathogen, the host, and the environment. This presentation is from the point of view of the host, aka the patients, and rather unapologetically, I might add. So this girl, whose name is Mariatu, I had just returned from a brief stint in Haiti and Boston, and when I was asked to see her in the hospital, this is a Port Loco government hospital, and I want to go back to this if we have time. This is a public institution in a setting in which public institutions, for many reasons, which are again all historically given, have been stripped of the staff, space, and systems they need to be able to save someone's life or to prevent illness. And the idea of asking me, an infectious disease doctor, to see her was, is there some opportunistic infection? These are not at all rare after and during the course of Ebola. Is there something else she hasn't spoken to anyone? She's been staring at the wall since she was brought into the hospital. What's the problem? I didn't have my neurosurgeon on hand, the sexy one. And by the way, you are just as worthy of that today as you were in 2003. Now, and this young man who's unrelated to her, his name's Ibrahim, and I wasn't his doctor either. By the time I met him, which was at the height, we didn't know it was the height of the epidemic, in Freetown. By the way, the most heavily affected areas in all three of the most affected countries. And by the way, Ebola didn't really spread anywhere else. Yes, there were cases of secondary transmission in the United States, Spain, Mali, Senegal, Nigeria. But it was really in these three countries and only these three countries where Ebola spread from forest to coast. And sometimes in a grumpier McNeil-like mood, someone asked me, so how did we stop Ebola? I went, we didn't stop it, the Atlantic Ocean did, and that's really what happened. Anyway, at the height of the epidemic in Freetown one night, I was, when I go there, and I still do this, I like to have Ebola survivor parties. First time I did this really early in the middle of the epidemic. So I know that some of my friends from the CDC, because, by the way, the Pope doesn't have a battalion, but the CDC does have one, right? So there are it was the highest concentration of epidemiologists in the world, right there in Freetown. And someone said, not from the CDC, you can't have a party for Ebola survivors at the Radisson. I said, oh yeah, watch. And we've done it every time. That's where I met this guy. He had just come out of the largest Ebola treatment unit, again, a public one, and that's important. His name's Ibrahim. And I, had never met him. I knew who he was. It was a smallish group of people who were nurses, doctors, some people from the CDC, and patients, most of them young, and there's a reason that they're mostly young adults who survived, right? And the reason is not because this was, at that point or later, not a clinically paltry effort. It's because they were young and strong, and they all lost members of their families, as I said. So this guy sat next to me because he's the only one I didn't know. And he said, I thought he was kind of brash and loud, which turns out not to have been the case at all. And he got up and gave a toast. And this isn't Russia, First of all, nobody drinks. They're drinking Malta. I, on the other hand, was drinking wine. Anyway, gives up, he and another guy who was called the chairman. I said, well, how did you get the name chairman? This is in the Ebola treatment unit. He said, because I try to organize the patients, to fight for better conditions. So we still call him the chairman. Anyway, they got up and gave a toast because they said, we're not Ebola survivors, we're Ebola conquerors. And so I thought he was brash and bold. He sat down next to me after this toast and said, I'd like you to interview me. Now, did Dr. Ayanian mention that I have a PhD in anthropology? He did? He didn't. Never does. But in 30-something years, I've never had anyone say, I'd like you to interview me. They're like, oh, here goes Paul again interviewing us, right? But I had interviewed a number of survivors, but in the way a doctor does, short social histories. And if you're a doctor, when we say short, we mean short. And I was surprised. He said, I lost 22 members of my family to Ebola, all in 1 month. And I was thinking, as I bet Sanjay is, when does this happen? In an earthquake, maybe? Or an avalanche, but not from infectious pathogens, usually. So if this was a public health desert, which is why Ebola spread, it was also a clinical desert, which is why it killed. We heard today the old saw that outbreaks are inevitable, but pandemics are optional. Outbreaks are inevitable, but death is optional, right? What Tony described, which is the care that he was able to give people, no American died of Ebola, right? That's because they were medevaced out of the clinical desert. So someplace else, Nigeria even, would be a lot better. You can trust me. So you don't have to trust me. I'm going to go through this now. Now, the social contract. I met this guy, this one over here where the right lung would be. Anyway, I have to take a sip. I'm stalling. Neurosurgeons, they don't know the difference between left and right either. Anyway, so a friend of mine is this tall guy, and he's at Brown University. It's in Providence, Rhode Island. And I'm sure they beat Michigan in football. This guy is from Monrovia. This fellow here I met at a similarly inspired dinner, I might add. I figure if I'm not going to be there full time, I might as well be convivial and fun when I am there. Right, Howard? I like to do that. Anyway, so this guy's a priest from Vietnam, and he was with this very formidable nun. They're mostly formidable in my experience. She'd been working there in Monrovia for 36 years. That means she went through the war, right? And in fact, all of the adult survivors that we cared for, helping them to not die, they all survived not just Ebola, which killed family members, but they also survived the war or were refugees from the war. So this Vietnamese guy who must have known, I didn't talk to him about Vietnam or, where he became ordained or any of that. We were talking about Ebola. This was, again, early at the beginning of what was called the Western Surge by a lot of epidemiologists, right? It comes from a forested region of eastern Guinea, which overlaps, as Tony said, with Liberia and Sierra Leone, and was heading west toward the cities, where there's nothing to block it, right? If it's a public health desert, there's nothing to block that westward movement. Right? It's like the Pope doesn't have a battalion, right? And if it's a clinical desert, and here's the question for the social contract: if it's a clinical desert, do people come because to you and say, "Would you please isolate me"? Do they come and say, "I'd really like to protect my neighbors and my family, so could you quarantine me? Could you do contact tracing? Could you contact trace me?" And I have never heard that. I mean, yes, there must be high-minded people like this guy. So I said, "Well, what order are you in?" Only a Catholic would ask that question, by the way. And he said, "I think was it St. Camillus? Is that right?" It was something like, "I am a member of the Order of Low-Level Bleeding and Chronic Anemia," or something like that. I said, "Well, what is your mission, your vocation?" He said, "Well, we take vows." So I went, "Yeah, I know. Poverty, chastity." What's the other one? I know, I'm kidding. And the fourth vow was to put themselves in harm's way in order to protect the destitute sick. That's a social contract, right? You look at nursing, you look at what doctors pledge to do, and they pledge to take care of their patients. That's the priority, right? But in this epidemic and in many others, or in some few others, and I'm saying this not with heat. This is not, anger you hear. This is sadness, right? We inverted those priorities. It wasn't the patient first. It was stop the epidemic, first priority. Second, protect the professionals, right? And third was improve the quality of care, right? And that's what I meant with, yeah, sure, outbreaks are inevitable. But it is not inevitable that we fail to bring the resources needed to bear to reduce what people might as well call case fatality, right? That is, how many people stricken by an illness die. At the end of this epidemic, in a place visible from the Monrovia airport, there was one outbreak chain or transmission chain, and this is in March 2015, involving 11 people, right? March 2015, all 11 of them perished. And in some reporting on it, case fatality wasn't even mentioned, right? Because it wasn't central to the goal of what most of us were there to do, which was stop the epidemic and protect the professionals. Now, the professionals, it turned out, paid a very heavy price. Those who did remember their social contract, they paid a heavy price. 211 nurses and doctors just in Sierra Leone died, and this was already a clinical desert. And this became very rapidly the leading killer of health professionals in those three places. So I'm not saying that I'm offering some alternative strategy. I'm just saying this is the context in which this sadness played itself out. And let me illustrate. Well, first of all, I don't need to do this. You already know it's a zoonosis, and not the first one to come out of some forested region of Africa, and it won't be the last. But the Yambuku, where this formidable nun is, this is the place in what is now the DRC where Ebola was first identified. And discovered is the wrong word, right? Because in order to discover something like a virus, you have to have a certain kind of staff space and systems also, right? You have to have, in those days, bulky microscopy that wasn't available even in the capital cities of these places. That's why a sample, after there were mysterious and rapid deaths among patients and their caregivers, I almost called this talk the caregiver's disease, right? Because every time since then, 1976, and also with Marburg, a related virus that was discovered in 1967, again because of a laboratory accident in a place where you could identify a pathogen like this. Suddenly, people in this hospital are dropping dead, and then their caregivers as well. Nuns, a priest, and some of you should be wondering, wait, it's a hospital, you say, a mission hospital with 100 beds. Guess how many doctors? 0, right? And this is not even uncommon. I mean, I'm sure, all of you who have worked in clinical deserts have seen the same things, right? So, it was a very sad thing for this Peter Piot, by the way, who was an infectious disease fellow in Antwerp at the time, was, gung-ho excited about going down to the Congo to investigate, along with some of his mentors and folks who came together from the CDC and other agencies like the Institut Pasteur. So they went there, and he, like this nun, was a Flemish speaker. And I'm sure you're all fluent Flemish speakers as well. Have you ever heard that language? Anyway, trust me, don't try to learn it. And he had to tell these surviving nuns who just lost their friends that they had been responsible for transmission by reusing syringes that were not sterilized. And on something rather tragic, unnecessary injections, right? Prenatal vitamins, those go down the hatch, not in the muscle, right? So this sadness and pathos is really what I hope you'll take from this critique of inversion priorities, not the assumption that we know how to make it better. I think we do know some things about how to make it better, but they really involve the political economy of risk, right? And not the crazy beliefs of the natives. And I'll go back to that in a second. But these crazy beliefs were from the caregivers, the professional ones, right? And they had been socialized for scarcity so that it became commonplace. It still is to reuse syringes after putting them in a pan of tepid water. That socialization for scarcity, I would argue, has infected our ranks on a much broader level. That is, we are socialized for scarcity on behalf of other people, not ourselves, right? And that you'll recognize declining standards, clinical standards, and you could say, well, that's just realism about the political economy of this part of West Africa, which is a clinical and public health desert. But to import lower standards clinically is a reflection, again, of our socialization for scarcity on behalf of others. Let me illustrate. Now, first of all, yes, you should be laughing at Paolo Casangian. When I'm seeing a patient in a clinical desert, first of all, one of the things that we want to do is not have a clinical desert, right? But you start somewhere. This picture is, I think, taken in Malawi, but it's, could be anywhere, any clinical desert, right? And they're all over the place. There are clinical deserts. I mean, Chicago is a trauma desert, one part of it compared to another, right? And that's why global health is really always about anywhere on the globe. But here you see a patient coming in. Let me give you the 3 symptoms. Fever, nausea and vomiting, 1 symptom, diarrhea. Now, what could that be? I've got WWPD. What would Powell do? Well, first of all, he would get a frickin' lab, right? Because any infectious disease doctor, and they love to do this. This is why our surgeon friends don't really like us very much if we stop and talk. They like when we put in the orders for their antibiotics, but they don't want to hear a long list. We don't have skills like you, all right? So we have to make up lists. But this is I made this in about 5 minutes, so that's my skill, right? The list is long And if you're in a clinical desert, there's no way to know if it's Ebola or not. And that's why it took from December 2013 to March for those international bells to ring, right? And are those bells like warm, Christmassy kind of things from upper UP? Is that Uttar Pradesh? No, they're not. They're the leper's bell. That's the bell that's getting chimed. And the idea in the past, these so-called first 24 epidemics, is ring it off and let it burn itself out. And, look at the correspondence. I mean, these are publicly available archives when there are any, right? That's what it's been. It's been the quarantine bell, right? But that can't be done in a place like a capital city, much less three, right? You're not going to wall off the whole of West Africa. And to its credit, the CDC never suggested that we do that. The CDC, having a battalion, was very much present and was not advocating that kind of travel bans and the like, which, believe me, were adopted by many places. Now, we felt the sting of rejection every time we came back, and it was very unpleasant. I may have even taken God's name in vain in reference to the governor of Florida, but not your boss, Eden. Florida, my home state. It was difficult, but we knew other people had it a lot worse, right? Trying to get back and forth. I mean, when first person, Thomas Duncan is a good example, right? They had to move, Catholic Church, by the way, I'm proud, did this, help move his family to another place in Dallas. I mean, maybe Sanjay covered this. I had already sworn off certainly social media. I didn't know that our president was actively tweeting about Ebola. He wasn't our president back then. But in any case, he has 102 tweets, I found out. I read them all later. Now, so how does it spread if it's not bushmeat? By the way, covered Newsweek in the middle of this, height of this. And I had never been to this part of West Africa until June of 2014. And I went there with, get this, about 100 surgeons. How would you like to hang around for a week in Freetown with 100 surgeons? We were working on a report about surgical care available to the world's poor or underserved. And it took 3 meetings. The first one was at Harvard where we launched it. The third one, I'll just tell you, was in Dubai. Now this is about surgical care for people in resource-poor settings. So some of us thought, well, we better have one of the meetings in a clinical desert, right, where we can maybe, meet some people and help them think through what we can do to help, et cetera. So we chose Freetown because of some connections there. I only knew 4 Sierra Leoneans. All 4 of them were doctors, and I'll introduce you to 3 of them in a second. And we had some connections through English colleagues, surgeons from King's College. And they had suggested this. But as soon as Ebola was identified as such in March, people were saying, well, you got to move the meeting, the conference, the workshop. And I said, well, I'm an infectious disease doctor, and I know that Ebola is not spread through attending medical conferences. So no, we're not moving it. But I hadn't been there before. And I met these folks later. There was all this stuff about bushmeat, in the popular press, American press particularly, and bizarre funerary rituals. Right? I try to make a joke with people my age. They're talking about bushmeat, and I said, you call it game. Never mind. Anyway, we knew that this was not a sudden orgy of bushmeat eating across this part of West Africa. That's a spillover event, and then it spread how? Human-human transmission, right? And what are the 2 most important parts of caregiving? Nursing the sick, and in failing, burying the dead. That's how it's been all over the world, forever and ever, right? You take care of your sick, and you bury your dead with respect. So these are not strange funerary rituals. These are just what people have to do in the absence of outsourcing this part of the caregiving to professionals, morticians, undertakers. And also nursing is outsourced because there are no nurses in the clinical desert. You just look at a town, forget about a village, a town, and see how many nurses there are. You'll hear about this patient zero, and his mother, she died shortly after him. She was heavily pregnant, and you read they're in a village with 31 households, and you read that she was seen by a midwife. You already know, if you've worked at it, that it's no way there was a midwife. There's a traditional birth attendant. Right? There are no nurses in the clinical desert. So to lose 211 of them, along with their doctor colleagues, makes this more of a clinical desert. Now, these three young people, they're all related to each other, and that's how it works. They're not related by blood. They were the parents where the right lung would be, this attractive young woman. I really can't tell right from left anymore because I'm used to looking at x-rays. Powell Kasanjian said, you got to look at all the studies yourself. So her father was first to fall ill. She was caring for him, but his father, that is her grandfather, was a traditional healer in the clinical desert. Of course people go to traditional healers. Diviners, throwing cowrie shells. I mean, that makes for good copy, right? Thank you, Donald, for not writing about that, right? But regardless of what the mechanism, what it is you do, you haven't had the training that a nurse or a doctor's had, right? So if you believe you can tell what someone is ill with through divining, a lot of people do, actually, especially in Berkeley. That was another one for Donald. So her grandfather, we're in the solid heartlands of Michigan. Her grandfather, of course, he became ill. It's spread by caregiving. He was a caregiver. Her father went to take care of his father. Then the grandfather died. Then he got sick, came back home to Freetown, and she nursed him. And that's her best friend over there, who was 16 years old. And that's her partner, the famous chairman. And he pitched in with nursing, as one did, but he also buried the dead. And this is at a time when you're already starting to hear about safe burial teams and dial this number. And most of the people that I interviewed, again, very briefly, scoffed at the notion that they could call a number and someone would show up. And you're hearing all about intransigence, superstition, and it went on and on. And a real anthropologist, I might add, would have said, yeah, sure, people believe that. They believe that everywhere in the world, right? That you should bury the dead, that you should eat game. Actually, someone said to me just yesterday before I arrived in Michigan, did you go to an all plant-based diet yet? So I'm sorry, I haven't done that. I eat game. Now, I said I knew 4 people. Tony wasn't one of them. By the way, is he not an awesome person? I mean, you can't be discouraged if you have public officials like that. You call on a Sunday his office to leave a message, he'll pick up the phone. And IAID. And he was a voice of reason also, as I'm sure Marty will agree, and always is. But these are 3 of the 4 doctors I know. Right lung. Byler Berry, student of mine at Harvard Medical School, was doing a master's degree. I had encouraged him to work on drug-resistant tuberculosis. Why? Because it's my specialty, and you always want people to do what you do. Seemed less compelling when his home country was falling apart, so he switched his topic. In the middle, Martin Salia, surgeon. You know how many surgeons there are left practicing in Sierra Leone? Right? During the war, he fled to Guinea, and he emigrated to the United States, to Maryland. And his wife, also Sierra Leonean, American citizen, as were their 2 sons. Right? This guy is probably known to some of you. One of the best-known Sierra Leonean doctors, and unfortunately now the best-known late one. This is Sheikh Humar Khan. He ran the only Lassa fever unit in the world. And Lassa is probably not that rare a disease, right? It's spread by kind of rat, common in this part of Africa, but across a broad distribution, other zoonoses. And so he was a specialist in hemorrhagic fevers. Lassa is another one, right? So this is in June of 2014. By November, 2 of them were dead of Ebola. Martin Salia, who was basically DOA here in the United States because his wife and others, including philanthropists, pulled together to get a medevac as Tony said earlier, there were only 3 places at that point that were accepting patients like this. Emory, damn, you can lord it over me again. Emory, Omaha, and Bethesda. And then Sumar Khan's story is worth mentioning briefly here. It's a very sad story, and I don't want to get pulled into the details of it, but I can just say that when we left that meeting in Freetown, it was clear. I went to go visit the first unit they were standing up, this is at the referral hospital, which is a colonial relic and a dump. And the holding unit was right across from the emergency room, which they called casualty. Another annoying British holdover, stupid words. Anyway, they had built this right with the same entrance. And they knew that wasn't a very safe thing to do. And then I hardly had the heart to ask. My wife was there too, and she said to me in Creole, she pointed to the wall, and there was a funeral notice for 2 nurses. She said, "Li genton la," it's already here. And it was. And when we left that day, I just said, this is a public health desert. Therefore, what's going to happen to stop this? And interestingly, a number of old Ebola hands had thought that things were under control by then. Right? And Marty would know this whole thing, this whole story, and I'm sure Donald covered it as well. Unfortunately, there was no way it could be under control. It could only be driven underground, right? Because people were afraid of control without care. There had been an army of people dispatched to help, but they weren't PAs, experienced clinician nurses, doctors who know how to put in IVs. That's not who showed up. Some did, right? But the numbers were really not largely clinicians. Because as I said, this control approach to Ebola was well established. Same for Marburg, right? Is you wall off the affected village or town. You hope that people inside, it's like what Marty described about ships, right, with a quarantine flag over, left to be sacrificed. There's more to that going on in these clinical deserts than you care to think. And I'll show you as an example. Anyway, if I have time, I'll talk about where we ended up. We were sent to these places, and again, our only desire was let's serve in public facilities, okay, with the Ministry of Health. And, of course, that's a choice. And it's what's the option? Build your own, right? A purpose-built ETU. But remember, by the time we got there, this is already completely out of control. This was even a month before, or 2 months before, the CDC predicted that if things kept on going the way they were, there could be over 1 million cases, right? So the one thing people say, well, it takes time to build a purpose-built unit. Time was what they didn't have, right? That's what they didn't have. So we said we will go in anywhere and do our best to work with those who have shown up. The Cubans, by the way, who reliably show up in the clinical desert, they were still undergoing training at this time. And so this was before them, but well after MSF was sounding the alarm. Now, this is what I want to show you. Now you think about, again, outbreaks are inevitable. Case fatality is optional, right? Because this is an Ebola treatment unit, except an ETU with no T in it, right? And if you look back, as Howard will remind me, and all historians, this has been going on for over 100 years. Since the beginning of the microbiologic era, the Pasteurian Revolution, guess what happened at the same time? Well, the Europeans occupied not just West Africa, but all of Africa, right? And this was the beginning of the control without care era in this part of West Africa. And if we think, that everybody in those places forgot about control without care, we should be so lucky, right? And what does that look like? Well, it looks like when you're talking about smallpox, it looks like ring vaccination only without much attention to the well-being of those on the other side. I forget what the beautiful term Marty used. It means trying to segregate Freetown so that white people don't get malaria. It's like, hello, vectors have wings. Plague, same story. The only reason they didn't segregate Dakar due to plague was because the French had made the mistake of empowering a small group of Senegalese citizens. Note that they were citizens, not subjects. The rest of them were all subjects, right? Who fought in the streets and in courts to say, no, you're not going to tear down our houses or wall us off. When the American army showed up with DDT, that's what stopped outbreaks of plague in West Africa, DDT. Now, they also brought these wonderful new things called antibiotics, but the French weren't that interested. There's no evidence that any Africans received these new antibiotics. And that's what I mean about control without care. So, I mean, it's just absurd to think that everybody there has forgotten about this, even though we have been lucky enough to forget about it. Now, I showed the Marburg. So I just want to say, Marburg, if you read the popular press accounts, not yours, Donald, I'm talking about I don't want to mention books by name, but there's only one. I mean, Ebola may have only caused a few thousand deaths, which, by the way, many of us think is utterly improbable, right? How could you know in a clinical desert, how do you know what people are dying from, right? But in one book, which did draw also on professional knowledge, right, expert knowledge, you read that Ebola Zaire is the worst. Case fatality is 90%. Marburg, case fatality is less, right? And then it'll give you a number, right? My favorite is there's one Ebola species where they put a little number after it, like 15%. There's only one patient, the artist formerly known as Pi Ebola. I think that's the one, right? These got mindlessly repeated, year in, year out. Ebola Zaire kills 90% of affected. Well, that's what they said about Marburg less, right? Because it was in Germany, as everyone knows where Marburg is. I keep forgetting that these are like infectious disease. A lot of people don't really know where Marburg is. It's in Germany. And Belgrade and Frankfurt were also affected. I said it was a lab accident. It was monkeys infected with this filovirus and it spread through labs. People weren't there doing basic research. They were making polio vaccine, right? And the case fatality rate in 1967 was 22%. The case fatality rate now in Africa, the clinical desert, is easily 90, 80. So again, what is it? Now, you know what the Europeans who were running those, occupying Africa would have said. They did say, and Americans did it too, right? If you see differential mortality, is it the environment or is it the person? It's the afflicted, right? And if you can't blame, their race, right, because there's no good evidence that it is race, then just talk about their beliefs. Just talk about their culture. And a lot of the anthropologists are either gone or not involved in the fight, or they're only too happy to fill you in with 500 pages of details about their strange funerary rituals. Right? So that's what happened during this epidemic. It's still happening now. We still haven't sorted out. Somebody will say, well, it's the WHO's fault. Well, but if they don't have a battalion, as Stalin acutely noted, how could they make a difference? You need staff, stuff, space, and systems. And that's not just health education specialists, town criers, contact tracers, sprayers of chlorine, right? I'm talking about people who can deliver care for the sick, because that's what the sick are after, always. They're after care, right? And if the professionals are absent or won't give it because they have other priorities, then the families are going to have to. And that is the drama of what happened during this recent epidemic, which was a very large public health endeavor and a very clinically paltry one. You need a lot of people to do this. By the way, here's Ibrahim again, and Yabom, who, I have a hard time talking about her experience, in part because it's easier to not know. Like if I see someone in an ETU or a hospital, I don't sit down and spend hours and hours talking to them about their lives, right? First of all, you only have a limited amount of time, before you start to have your own heat stroke, right? But I have spent a lot of time with them after. Not when they were acutely ill, but after. And it's very, again, just know this. Everybody their age, she was 41, I think, when she got ill. They lost family members. They survived, but they also survived the war. And those stories are very hard to hear. Ibrahim after that night of the successful party at the Radisson, no one objected at all. As long as you pay the bills, Radisson's happy. You can take that to the bank. He said, I want to help. I want to help. And this guy's, first of all, he just lost 22 members of his family. It took me a year just to sort out who was who. I'm not even sure, not sure I have, right? He was still frail looking, like everybody who came out of there alive. Almost all of them looked like they'd been through a wreck, right? This is not, as I said, an acute disease, really. It's a month of illness anyway. And he still had that look, and I was thinking, if I were you, and I said this out loud, if I were you. Now, he's an orphan now, right? So, I mean, paternalism, bring it on, right? Perfectly happy. Finally, I made Donald laugh. That's like 30 minutes of trying. So in any case, I was saying, I don't think you should do it. If I were you, I would never go near an ETU again. And he said, but I'm immune, aren't I? I said, we don't know. I mean, we think, but that's not reason enough to put, look what they used to say about, I didn't say this, but I am showing off a little bit now. What they used to say about TB, once you got it, you're not going to get it again. Wrong, right? So we just didn't know enough. But he kept at it. This was, in the end of October 2014 is when he said that with the toast of the conquerors, and he kept on saying it. And in January of 2015, that little girl you saw, Mariatu, she was again facing the wall. She hadn't said a word. She'd lost her mother and siblings and other family members. She hadn't said a word. Her father, by the way, wasn't standing around like that. I thought somebody else was her father. Because he even said later to me, and this is through a translator, because I thought Flemish was bad. Anyway, he said, I just didn't know if my daughter could be fully human again. And I was thinking, wow, of course that's what you're thinking, if she hasn't said a word. And she's been in the ETU and he hasn't. And now out she comes out, a wraith weighing 27 pounds. I called my friends, the surgeons, and another one who's an eating disorder specialist, both of them at Harvard, and said, so how are we going to get her fattened up, right? Because she was dying, and, put down an NG tube so you can feed her, but what do you feed her? And she, she didn't like me, I can tell you that. She took out the NG tube. I put it back in. That kind of thing, as one does. And so Ibrahim, and I won't forget this, a number of things happened at that minute. This is in the public hospital. So I can see all the beds and where they're on. This pediatrics. And I remember every patient who's in what bed. And one of them was a girl named Isatu, who, again, had come out. And by the way, the sequelae include blindness, seizure disorder, of course, major depressive disorder, right? The list goes on, arthropathy. Some people even believe kidney failure. Can't know in a clinical desert, right? You have to study it. That's what the Prevail study that Tony was talking about is about. What are the sequelae? We've got thousands of survivors, thank God. Anyway, I remember what happened. Isatu, this girl, and I had been going in and out of there, and I said, well, Ibrahim, paternalism, yes, you can come with me, but we're not going to ETU. We'll go to the hospital first. And I had already promised to help with this girl, Mariatu, as if I could do anything, right? Put in an NG tube. So, and the nurses there, by the way, the Sierra Leonean nurses, they had huge losses, as you might imagine, in all. They'd lost their colleagues, right? And the disease controlling machinery working as it did, they just shut down the hospital, right? And but you got to have something somewhere to take care of people, and they don't all have Ebola, right? So the nurses were having a hard time. They said she's brain damaged, right? And I didn't say, well, what assessment tool did you use? I just said, okay. Anyway, so we walk in the door. I'm with Ibrahim. He was wearing that shirt. And it's probably that day, although people sometimes reuse shirts like I do. And he went right over. He'd been looking at her picture on the viewfinder of, you remember Beck Collins from Partners in Help. She's a photographer and director of communications. And she came back from this town, Port Loco, and said, look at this girl. And he was jumping out of his skin, saying, I really want to go help. I could help people like that. I could talk to them. And it was the next day he went, and he walked in, sat down on the bed, and then two things happened at once. She pulled on his shirt and pulled herself up to his ear and said something in his ear. She hadn't spoken to anyone, her own father, me, the nurses, and this woman who we called Grumpy Grandma, who was sitting with her. She was kind of grumpy. I mean, again, who knows what she went through, right? And I was about to say, hey, wow, this is fantastic. My incurable psychopathologic optimism is again warranted. And then this other girl had a seizure and fell off her bed, which meant there were no bed rails on it, right? So I missed the rest of it for like 15 minutes, like, somebody help. You know, and of course she's incontinent on me, right? And I'm thinking, oh, now I get to have Ebola. Great. I didn't really think that. Well, yeah, I did, actually. Anyway, I was kind of scared, to tell you the truth. Anyway, so it was hours later that I asked him, well, what did she say? And he said, there's this certain kind of juice I like, and these cookies, could you go get me some? What? That's what she said to him. And then he went and did just that. And he ended up moving there, and he said, you watch. You know, she'll look a lot different when you get back. I'm going to just skip ahead to that so we can... No, I'm not. I'm just going to say these last things. So when I'm talking about staff, stuff, space, and systems, right, this is not rocket science. Like NSA, they do rocket science. Probably. No, that's the other guys, NASA. We couldn't even find gloves half the time, right? This is in Liberia, home to Firestone Rubber, right? Finding gloves was hard. Wall Street Journal ran a piece. I don't like their op-ed people either. Ran a piece about this. Space. Well, I told you we made tough choices. I don't know if they were right. A lot of people think they were. So when I say we went into facilities that were public, this is one. Guess what it was? An abandoned vocational school. What kind of building gets abandoned in Sierra Leone? And it turns out it was part of the disarmament effort. It was always built at the end of the war to be a temporary structure. That's where the ETU was. So the purpose-built ETUs that everyone said you should wait for, in Liberia, they cost hundreds of millions of dollars. They were built by military subcontractors, right? And 9 of 11 in Liberia never saw a single patient, right? 8% of Sierra Leone survivors walked out, or were carried out of this one, and it took, a couple $100,000 to. I mean, yes, it was a shithole, right? Yes, it was unpleasant to work there, but again, time was the one thing these people didn't have. And on October 26th, when we went there and hung our flag, there were plenty of other flags flying, by the way, and they were doing other necessary things, right? I'm not suggesting that all of these other activities are not necessary. I'm just saying they weren't clinical activities. They weren't caregiving activities, right? Like somebody else was making our meals. Somebody else was doing the safe burial teams. Somebody else was doing health education, which, by the way, started out stupid, right? Stop eating bush meat. Well, that's hundreds of thousands, if not millions of dollars of your tax dollars, by the way, going into dumb advertisements. Ebola is real. Well, if you lose 22 people in your family, you have a sinking suspicion it might be real. Sorry, that's sarcasm, and I'm above that. Now, the big problem, and here, this will be my dismount soon, Howard. The big problem is this was a clinical and public health desert before Ebola, right? Sierra Leone, for example, highest maternal mortality ratio in the world before Ebola. And, what's happening now? Of course, these are all estimates and guesses, right? Because how can you know if you don't have a surveillance system, if you're in a public health desert and a clinical desert, you don't really know the numbers, right? But that or thereabouts. So now what? And this is something that the reason I'm here, well, because my best friend from college told me to come. But the reason I'm here really is because we need allies, right? We need allies who understand that the same thing that happened after the wars ended in Liberia, Sierra Leone, that's how it, and Guinea too, no actual civil war there, but if a quarter of the Sierra Leonean population are refugees in Guinea, and your own military is part of the peacekeeping troops, right, then you're very much affected by war. And Sierra Leone and Liberia were leveled by it, right? Leveled. So the clinical desert and the public health desert, it has a history, just like control without care has a history in this region. So what happened after the wars, if you want, or war, is that there wasn't an investment in staff, stuff, space, and systems, right? And it's hard to say that because some people came and worked their tails off, right? But not long enough. It's already been said it takes time to get out of the clinical, to water the clinical desert. It certainly needs to involve this boring term, health system strengthening. By the way, I want to try this out on you all. No one ever is interested in health system strengthening, so I propose we call it Beyonce. Training and capacity building. I mean, another boring term, capacity building. But how can you water a clinical desert if you don't have nurses? And doctors are handy sometimes, especially if you have surgical disease, right? But no, I mean, what development expert's going to... I have the worst story of all in a second. What development expert is going to say, yeah, you know what? After the war, training doctors and nurses is a top priority for our aid dollars. But they should have said that, right? I'll tell you, I'm saving my mother of all outrages for a second. CAT scans, well, forget it. Poor people don't need those. Research, I mean, there are public health Luddites too, right? And Marty probably knows some of them, although I'm proud to say our own Centers for Disease Control Prevention are largely Luddite-free. You need research. How do you know if a rapid diagnostic works? You have to have research. How do you know that there's a vaccine is effective? You have to have research. This is not, extravagant, even in a clinical and public health desert. You have to generate new knowledge. So this never happens in emergency responses, but it could. Now, this, by the way, that was the place I went in Liberia. That was the isolation unit, okay? And by the way, the district health officer, who was a nice lady, she said, I'm so proud we're an Ebola-free district. And I wanted to say, but I did not, and my mother would be proud, I wanted to say, you're a lab-free district, honey. How do you know? I didn't say anything. I went, well, keep up the good work. That was the isolation unit. And of course, no one would go in there. They fled that, right? They fled the hospitals, which were carefree and lab-free, and they fled the units. So if we did turn it around, if we did, and it wasn't the Atlantic Ocean, it's because we finally started to integrate prevention and care. We realized that the disease control only model had already failed. Just like travel bans, quarantine without care always fails. And any historian, some of my best friends are historians and doctors, they'll tell you this. They'll say, oh yeah, that happened already. And then they'll tell you about the archive. That, by the way, the other building, that is the world's only Lassa fever ward. So they may have had a really nice lab, world class actually, funded by the US government, branches of the military, partnered with CDC, et cetera. But that was the ward. No wonder all the nurses died, and Humar Khan too, on July 29th. And the thing that went viral, if you'll pardon the expression in the papers, was that he died without getting ZMapp. But that's not the real sad story. The real sad story is he died without getting supportive and critical care, right? And that's why all the Americans and most of the Europeans survived, no matter what their color, right? Because I guarantee you that if it had been 1900, that's what they said. Well, Africans, they have different capacities, right? This is about context, as has been said by everyone here. And changing the context requires investing in staff, stuff, space, and systems. That we still haven't done. Now, my outrage, and I'll close. After the earthquake, And Sanjay, Sanjay was there. It was on the USS Vinson that you plowed in the OR. I like that. I like ships with ORs a lot. The comfort especially. Anyway, in the middle of all this is the nursing school, speaking of nursing. And I've been working there for 25 years already, and we lost a lot of our staff and friends. Some of them, obviously most of them Haitian. Not all of them, though. And this is right next to the General Hospital, where Sanjay was there. So I am saying Sanjay. It's because of French, another useless language, I might add, that I speak fluently. If I could boot that out and put in great Mandarin, I'd do it. But anyway, I'm making light because this is actually hard for me to even look at the pictures and remember, trying to get those girls. Most nurses are women in Haiti, whereas that's not the case in a lot of places. But trying to get them out of there and failing, or having them brought into the hospital. That's the hospital. What's left standing of it is in the corner. And so, I would say whenever I was given a forum, and I got a lot of time, and more than I wished for, to speak to VIPs and various people. I said, we really need to have an academic medical center, a teaching hospital, a university hospital, right? And they said, why? This is non-Haitians, mind you, but very powerful, influential people. I said, why? I said, well, because their own teaching hospitals were just destroyed in one day. How about that for a reason, right? And I'm telling you, I went to all these meetings and was a good boy and didn't fuss or yell. And, I said, well, we have to have someplace that quality buildings in which to train doctors, nurses, and others, including epidemiologists, lab people, et cetera. And so we said something like this, for example. This is in Mirbalais, which is outside the earthquake zone in a place that I've been working for over 30 years. And I know there are a lot of people in this room, John Ianian being one of them, but many of you who supported Partners in Health after the earthquake. And this was a time of many meetings and many charrettes. I didn't even know what a charrette was. But very little in the way of implementation. That's what's going on in West Africa, by the way. Right? Fortunately, I'm able to show you a real building I'm kind of proud of, as are others. That's the largest solar-powered hospital in the developing world, and it is this place where most of Haiti's, the #1 training site of Haitian doctors and nurses. Right? You have to have institutions like this in clinical deserts if you want them not to be clinical deserts. And I would guess that a clinical desert that's strong in public health is not a real thing. It's a fake thing. And Marty said it beautifully and politely, right? You can't have a public health fortress that is a clinical desert. That's a mixed metaphor. Sorry, Donald. This is what we need to do. And we can't do it if everybody's already declared victory and is headed off to the next emergency, which they've done already, by the way. Not just in Haiti, but in Liberia and Sierra Leone. And try extracting money from the big funders. They're like, oh, Ebola's over. The epidemic's over. I said, no, it's not over. We have just as much risk now because it's even more of a clinical desert now because all the doctors and nurses, so many of them have died. The University of Liberia Medical School has had 25 faculty members. Harvard Medical School alone has 11,432. One medical school, right? 5 of them died of Ebola, not the Harvard ones, the Liberian ones, and 5 left, so that's 15. That's a clinical desert. And it's a public health desert, too, because those things are always going together. And you don't replace them by shipping in people like me to stay there for a short while. You have to invest in building and staffing nursing schools, medical schools, technology schools, and then the clinical spaces in which to train them. And that is a noble thing for humanity to do. If you want to get out of Zika, if we want to see less suffering caused by pandemic disease, or even know that Zika's been around for decades and that it almost surely causes the complications that Tony said it does, right? You have to have. In that hospital, I saw a boy. They asked me to see him. He was 15, I think. And he was intubated. Now, there you go already. He's intubated. That means he's on a breathing machine in central Haiti. And he'd been intubated for 12 days by the time I saw him. And they said, Paul, we want you to see this boy. Tell us if he has Zika. He had Guillain-Barré, right? I said, okay, and I went to see the boy, and he had already just been trached, so he could talk to me, you know. And there was actually a neurologist from the Brigham there who was learning how to speak Creole but had a really heavy French accent, and I didn't mock him at all. So he wouldn't let me talk because he was doing his Creole thing. It was good, but it was just really Frenchy, you know. And this kid was saying, tell him, hold on, let me tell him. Anyway, I saw him, and, you know, he's AFib, he doesn't have fever, whatever. I went back to the emergency room attending, a young woman. Again, in the clinical desert, you have to have Haitian attendings, right? Haitian professor types. And then I went to the director of the ICU, also a woman, also Haitian, and said, look, gals, I don't know if he's got Ebola because there are about 17 things. Let me make a Powell Kazanjian style list for you, right? I don't know if it's Ebola. I mean, I don't know if it's Zika. We'll get the antibodies, et cetera. But you already saved his life, right? In a way, it doesn't matter in this case, because what he needed was critical care. No one who needs critical care in that part of West Africa is going to get it, because there are no ICUs there. There was one trauma center built by Italians. They said, this is just for trauma, no Ebola, please. Of course, that didn't work for them, right? They got overwhelmed like everybody else. But we need facilities, and 9 beds is not going to do it. This is 320 beds. Anyway, that's the last image. That's what Mariatu really looks like. And to show that I'm an incurable optimist fellow, they arranged, and Ibrahim moved there, by the way. He moved to Port Loko, like he promised, that I'm not coming back to Freetown until she's home and safe. So when I go back, you know, they treat me like a VIP. Wouldn't you if I threw parties for you at the Radisson? And they surprise, you know, I'm up in this little village in the middle of nowhere, and there's Mariatu. And I knew they were going to. They said, we have a surprise for you. It's always going to be a patient like that. So she sat on my lap, and I said, I'm so sorry I didn't bring you anything. You know, next time I have some candies. She said, next time I'll bring you something really nice. You know, what would you like? She said, an iPad. She got an iPad. Is that cost effective, Howard? Thank you all very much.
Paul, thank you very much for your riveting firsthand account of all that you've worked toward in Haiti, in West Africa, and really bringing to us the personal dimension of this. You know, we can talk for hours and days and weeks and months about the statistics and the science, which all matters very much, as you said. But we also need to remember the patients who are affected, and you did that so well for us. Thank you. So we have time for a few questions before we'll break for a reception.
Hi again.
Hi, Zhao.
Hi.
You think I forgot?
So in your book, Reimagining Global Health, there's a chapter.
Say that again, would you? In my book, what?
So in Reimagining Global Health, you talk about the growing epidemic of mental health.
The what? Of mental health?
Mental health illness in the developing world. And there was like one of the critics of that who was saying that the problem with standardizing norm of diagnosing mental illness is that people come from different social, ethnic background and have different historicity. How?
Like I said, Berkeley.
Berkeley, yeah.
Never mind. Keep going, Zhao.
Like what's your experience with trauma, especially after the earthquake in Haiti, or like in places like Doke where people lost everything?
Well, it's a terrific question. Thank you very much. You know, we're lucky when we have a good diagnostic, right? But those require investment, right? And even if you're talking about something, we all think about HIV diagnosis and staging is super easy, right? But it wasn't in the beginning, right? And with most major mental illness, nosology, that is the knowing what's what, has been long contested along just these lines. In fact, if you're a physician anthropologist, as I am, you find a lot of people in medical anthropology really quite interested in this and have spent their whole careers working on it. As far as trauma goes, and I know you're talking about the trauma, that unseen trauma, as opposed to the kind of trauma that Sanjay deals with, there's no question that we're underdiagnosing it. And how could that not be true, right, in a clinical desert? Because, you have to sit with people, and regardless of what survey instrument you use, you see a lot of trauma. PTSD as a category is a recently confected thing, from around the time of the Vietnam War, right? But there's no doubt that there are very similar symptoms and a pathophysiology or a physiology of this across the world. So we're underdiagnosing it, and I think of some of the work in Haiti after the earthquake. My colleagues, include some of whom are psychiatrists, but many of whom are not nurses. They're nurses or psychologists. I once wrote, I'm sure you all read this, in Ethnopsychiatry. Truly. I forgot I wrote it too. But I just said there were more Haitian psychiatrists in the city of Montreal than in all of Haiti. And I think that's still true, right? So that requires training programs and having the staff, space, and systems to take good care of people, right? If they're in Montreal and Miami and New York, which is where they are, it's because the working conditions are not acceptable, right? And it's not just about salary. People want clinicians, in this case psychiatrists, I'm talking about psychiatric nurses, et cetera, they want to be able to take care of people, not just based on their ability to pay, right? And I've seen that all over the world, right? So we have a long way to go, but it's not a different, and this was, Marty made this point as well, it's not a different set of problems. Health system strengthening, aka Beyonce, has to include mental health, because there's no health without mental health, a slogan, but a true one. So I don't think that culturally specific patterns of presentation and course are as important as having a system to take care of people with serious illness, affliction, injury. And that includes mental illness. Thank you.
Other questions? One in the back.
I mean, that's like downright concise for me for an answer.
Hello, I'm Kate Collars, a medical student here, and I was curious if you could speak a little bit in some of your other writings and just looking at your work. How do you balance the need to develop these systems and provide care to patients? Because that's really what we have taken, an oath to do. But still getting the resources you need and sort of working in the constraints of the reality we're in. So how do you balance getting the resources you need while not losing sight of the care that you need to provide? Just because in my experiences with some of that, I've noticed that can be lost with terms like cost effectiveness or trying to get and so I just am curious how you appeal to that or get resources while not giving
Well, one
in.
thing I've learned is sarcasm is not an effective fundraising tool. But I will say this. I think I just met someone who's Shirley here, and she's about to start a nurse practitioner program. And I said, good. And she's already in a public health program. I said, good, it'll keep you honest, right? Some people might be so gifted as empaths that they don't need the immediacy of practice. I'm not saying clinical practice. I'm saying practice, like actually, helping someone get groceries is still praxis. Some people might not need that. I do, right? If I can spend some of my time doing clinical work, I tend to be more cheerful and less grumpy about well, first of all, I have to say one of the hardest things for me is the idiocy of the comments from my peers, right? When I say idiocy, I mean, like, if you are talking about cost effectiveness and you haven't even done an analysis that bothers to make a distinction between cost and price, and that's like pretty basic economics, right? And I mean, I don't say, boy, that's idiotic. Well, I do sometimes, and I shouldn't. But it's just so primitive, right? And you think, and that's just cost. What about the other side of that hyphenated thing? Effectiveness. Well, as you just point out, it's hard to know how to measure effectiveness. I mean, you can go with old school standards like death and life, but it's not easy. You know, that part's easy. So I think that's a general and a very personal comment at the same time. Some people, like me, are not good enough people to not need that regular reminder from patients, right? And that is the risk of policy in general. It's so experience distant, it's so far away, you know, from the everyday suffering of everyday people that you get lost and you start getting fooled by something that sounds really impressive. Like if you're told that, you know, treating AIDS with the only treatment we've got, which is called antiretroviral therapy, that treating AIDS is 28 times less effective than preventing it, that could be intimidating until you stop and say, wait, how do you prevent it? What if it's gender inequality, violence, all the stuff I write about that clearly some people do read? You know, critical thinking is another part of this, right? Of knowing, you know, if we're being socialized for scarcity on behalf of others, you should recognize that. Check yourself, as they say in scholarly language.
We have a question here.
I'm just so funny. Cost effectiveness, hilarious stuff.
Hi, my name is Lily. I graduated from U of M in anthropology, and I've been living in Peru for the last 2.5 years doing research on TB. And in the short time I've been doing research, and
Bless you.
In the short time I've been doing research and the couple of conferences I've gone to, I haven't seen many anthropologists. And I'm just wondering.
Ooh, that must be nice for you.
I studied anthro.
So did I. I've been around thousands of them at a time.
My question for you is, what do you think is the role that anthropologists need to play in global health and in infectious diseases such as Ebola and tuberculosis? And do you think we have a responsibility for translating critical thinking and critical writing into collaborations with public health officials and physicians?
Yes. Do that. I'm serious, okay? Because it's a great comment parading as a question. And it's a good one. I like it. You know, critical thinking is what we have to contribute as anthropologists, right? And so do sociologists, political economists, political scientists. Just kidding. But critical thinking, as historian, history is the queen of the social sciences, right? Because, you know, that's going to tell you if you have the right sources and archives, then you can look and say, wow, I guess we didn't do so hot on that one, or we did great on that, whatever, you know? So I think that's the main answer. And read Adia Benton's work, all right? So she was she's an anthropologist, now at Northwestern, which makes me sad because she was at Harvard for a long time. But she, all through the epidemic, first of all, she's writing a book, her PhD thesis, called HIV Essentialism, good book too, and published by Minnesota. Michigan lost it again. She's, you know, she's with child meaning the book child and the other kind of children, the short-statured ones who won't eat their vegetables. And she still wrote the whole way through. Not because she was sitting there exploring, you know, the role of bushmeat in funerary ritual, because she knew when she was hearing BS or not, right? And she wrote about it and blogged about it and did everything. That, to me, is a very dignified role for any kind of scholar, but especially anthropologists.
Well, thank you very much.
The hook. Thank you all.
So we want to thank you all for joining us this afternoon. We'll have a reception immediately following that you're all welcome to, just outside the amphitheater. And I want to thank Howard, Alex Navarro, who took the lead on much of the planning for this, Heidi Mueller, who helped with the logistics, and really appreciate your contributions to the discussion today. Thank you.
Drive safely.